So we are going to start with COPD. COPD is basically a progressive irreversible condition of the lung characterized by the chronic obstruction to airflow, with the many patients have periodic exacerbation, gas trapping, and lung hyperinflation at end stages and weight loss, and those things are happening. So spirometry is required for the diagnosis. So they are going to ask you what is the one thing that you would like to do to confirm your diagnosis. That's spirometry, not X-ray. Then gradual decrease in FEV1 over time more rapidly with each acute exacerbation. So that's what's happening here. Clinical and pathological features of the COPD. So chronic bronchitis and emphysema, both are two types of COPD. So clinically, bronchitis is basically productive cough on most of the days, at least three consecutive months in 2 progressive years. So 2 years, there is 3 months which has productive of in most of the days. Obstruction is mostly due to narrowing of the airway, so mostly happen in the upper respiratory tract by the mucosal thickening. So airway changes include the increased goblet cells and those things, so you just don't need to know the pathology of it. Coming to the emphysema, dilation, the obstruction of the airway spaces. So this is the lower respiratory tract involvement. To the terminal bronchiole without the obvious fibrosis. So that's why it's happening, increasing decrease elastic recoil. So that's why the airflow is not properly coming out and air is trapped inside. That's why some people also develop pneumothorax in this condition. Not a very big pneumothorax, but a very small pneumothorax in some part of the X-rays. Coming to the types, centrilobular, pan-encinar, just know they're in centrilobular, they are typically seen in the smokers and the people who have primarily affects the upper lung zones. And the pan-encinar is basically in those conditions where there is already like alpha-1 antitrypsin or anything that is already involved. So it's very less likely the pan-encinar one, the centrilobular where the smokers are the conditions, that's more common. So chronic bronchitis, the upper respiratory tract infection, and then emphysema in the lower respiratory tract infection. Coming to the complications, they can ask you in the CDM question, what could be the complications of the COPD? So that's why chronic hypoxemia, polycythemia, because of the hypoxemia leading towards the polycythemia. So a lot of people present with the pink faces because they have polycythemia. So there is one of the condition with the COPD is basically pink puffers and blue blotters. You don't need to go into very detail of this, just letting you know. Then coming to pulmonary hypertension from the loss of the vascular bud, core pulmonale, then because they develop the CHF, and then pneumothorax, depression, and COPD exacerbation. CO2 retainers, what happens is on ABG retainers have chronically elevated CO2 levels, usually with a near normal pH. So pH level is normal, but the CO2 is elevated because CO2 is trapped inside and it's not excluded outside properly. Maintain O2O saturation between 88 to 92% to prevent exacerbated hypercapnia. Due to worsening ventilation perfusion mismatch, Haldane effect, and decreased ventricular drive. So just remember this one. What happened is oxygen is maintained at 88 to 92% and carbon dioxide is retained inside, but the pH level is normal. Coming to the risk factors, the most important one is smoking. Otherwise, the other factors are environmental. Usually in their scenario, in the MCCQE1 scenario, they give that this actually person is been smoking for a certain period of time. That's why he developed this one. Exposure to the wood, smoke, or other biomass. So he has been exposed to some smoking, or maybe the first hand smoking, or maybe second hand smoking. Somebody who was with that person and he is being experienced with that smoking. Along with that, age, family history of atopy, like having that history of asthma, history of childhood respiratory infections, lower socioeconomic status. So these can be the one of the risk factors. Remember, the first line therapy of COPD who smoke is smoking cessation. So if they ask for first line management of COPD, it's nothing but smoking cessation counseling. So as a family physician, you need to know what is the first thing you would like to do. Now, the clinical features, as we already discussed, the chronic bronchitis and emphysema, the blue blotters, and the pink puffers. The chronic productive cough, purulent sputum, as we said, this is the upper respiratory one. So the most important feature would be the cough, the productive cough, because it's productive, so they will be producing a lot of sputum. So don't mix this is a pneumonia. It is chronic bronchitis because there is a condition where this is involved with the smoking. So this is blue blotters. What happened is, since the upper respiratory tract infection is blocked, that's why the patient will be diagnosed with the cyanosis. Peripheral edema, because they are not breathing properly. Crackles, wheezing, and prolonged expiration, frequently obese. So investigations, what happened is FEV1 is decreased, FEV1 divided by FVC, both are decreased, and then normal TLC or normal DLC, differential leukocytosis. Then chest X-ray shows AP diameter normal, because in asthma, AP diameter is increased. But in COPD, the AP diameter is normal, increased bronchovascular marking. Just go and see the picture of chronic bronchitis. How does the X-ray of a chronic bronchitis looks like? Then coming to emphysema, it's basically dyspnea, minimal cough, tachypnea, and then decreased exercise intolerance. That's why they develop polycythemia. That's why they are called pink puffers. Pink puffers pursued lip breathing because they are unable to breathe properly. That's why their lips are just in that particular position where they can breathe easily. Accessory muscle use because they are not able to excrete all the carbon dioxide outside. That's why they're using accessory muscles. Cactic appearance due to the caloric consumption because they have been using a lot of accessory muscles. That's why. From the increased work of breathing, hyperinflation, barrel-shaped chest, hyperresonant percussion, because the air is trapped inside. That's why a lot of pink puffers develop pneumothorax, decreased breath sounds, and decreased diaphragmatic excursion. What happened is FEV1 is decreased, FEV1 to FVC, so the both are kind of same. TLC is increased, hyperinflation, because what happened is a lot of total lung capacity is increased because a lot of air is trapped inside. That's why it's not excreting properly. So the total lung capacity will be increased. Then residual volume is increased and DLCO is basically decreased. Chest X-ray AP diameter is increased in this one because they have been using accessory muscle. Now, how will you differentiate if this is emphysema or asthma? Asthma has been coming out from a very early age of the patient. So pink emphysema comes with after certain age after use of smoking. So that can also be one of the differential point. Along with that, this person will present with a pink puffer, like having this pursued lips with the pink skin and all of those features, but this is absent in asthma. Flat hemidiaphragm, decreased cardiac silhouette, and increased retrosternal space and decreased peripheral vascular marking. So just look into the age of the patient, how they are presenting, if they're presenting in the emergency department. So these things are very, very important to make the diagnosis and how you are going to approach that person. Gold classification of the severity, if you can just remember this one, it's totally fine. Just remember that more than 80% is kind of okay, but if this is less than 30%, that is very severe. Treatment of stable. Now coming to the stable and unstable. Now, if this is stable, it means that person will be coming into the clinic. So first thing first, you're going to start with the prolonged survival, start with the counseling. You are going to tell that person that he or she needs to quit smoking, counseling, nicotine replacement, so varenicline, bupropion. So they can ask you what are the medicines you will prescribe. So varenicline, bupropion to help for the smoking cessation. Combination therapy can be used. Now coming combination therapy of nicotine replacement and varenicline. They are talking about these ones. Vaccination, annual vaccination, which one? Influenza one. Home oxygen. Patients, if you see in Canada, there are a lot of people who has very small cylinders. They're walking around in shopping malls. So this one, they are using a home oxygen, prevents core pulmonale and decrease mortality. Now, if that person is not willing to quit smoking, then giving home oxygen is no big deal. So you are not going to give home oxygen if the person is not willing to quit smoking, because smoking cessation is one of the important thing, and then only home oxygen will work. That's why if the scenario says that they are not willing to quit smoking and demanding to give home oxygen, so then you are going to do the counseling that if they don't do smoking cessation, this home oxygen will not help them. That's why it's important in the scenarios they have already discussed the smoking cessation or not. Prevent cold pulmonale and decrease mortality, although it helps with that core pulmonale and decrease mortality. But if smoking cessation is not started, the home oxygen will not work. Partial carbon dioxide less than 55 and partial oxygen carbon dioxide 55 to 59 with the core pulmonale. So you are going to give the home oxygen. So they have given two indications where you are going to give home oxygen. But along with that, if smoking cessation is not stopped, you are not going to give home oxygen. Although it's not mentioned here in Canada Quebec, it's already mentioned that you need to do the smoking cessation. then you are going to prescribe the home oxygen. Otherwise, if the person is not willing, it will only exaggerate or exacerbate the COPD condition. That's why it's very important to start with the smoking cessation, vaccination, and then go for home oxygen. Starting with the bronchodilators, what is a symptomatic relief? No mortality benefit. Only if the person is having the symptoms, it will help with the symptoms. So starting with the short-acting anticholinergics, what are those ones? SABA. SABA, rapid onset but significant side effects at high dose. Hypokalemia, it can cause hypokalemia. Short-acting anticholinergics slightly more effective than SABA. So anticholinergics are more effective than SABA. So using a combination of both is superior to monotherapy. So if you are using short-acting anticholinergics like ipratropium bromide along with SABA, it will be effectively more superior. So if they give in a scenario, what is the most effective one? So you are going to choose on the basis of that. If they ask for the first line, then you're going to start with the short-acting anticholinergic. LABA and long-acting anticholinergic can also be used. More sustained effect for the moderate to severe COPD. LAMA more effective at decreasing exacerbation. If they are talking about exacerbation, then you are going to give the LAMA, long-acting. Then using a combination of the both in superior than monotherapy. Corticosteroids plus LABA combination can be used, but patients with a frequent exacerbation of end-stage diseases. Then theophylline, mostly in the corticosteroids, we don't use inhaled corticosteroids in COPD because what happens is if there is an infection, it can be exacerbated with a corticosteroid. So if there is an option of not using it, go with that one. Theophylline, weak bronchodilators, limited evidence to suggest the combination with the bronchodilators. PDE4 inhibitors, Romlicost and anti-inflammatory medication. So these can be used, but this is usually prescribed by any respirologist or somebody who is in this field. Usually we stop at the SABA or short-acting anticholinergics along with if antibiotics is needed. So we are going to go with that. Inhaled corticosteroids, monotherapy has been shown to increase the incidence of pneumonia. So that's why we just stop where we are not sure and we don't need to give COPD person a corticosteroid because it increases the risk of infection because the air is trapped inside, sputum is trapped inside. So the infection could be worsened up. Inhaled corticosteroids should only be used as a part of combination inhaler if necessary, otherwise not. With the LABA or with the LABA and LAMA in patients with the history of exacerbation and end-stage disease or concomitant asthma. So in those conditions where there is a history of exacerbation or end stages, if you think that using inhaled corticosteroid will increase their lifespan or help them with the condition or with help them with the asthma, in those conditions we will go with the corticosteroids. Otherwise, if you have the option of not using it, then don't use it because in our level, I don't think so we give corticosteroids. Surgical lung volume reduction can be done, and along with that, lung transplant can be done. Others, patient education, eliminate respiratory inherents or allergens like occupation if the person is exposed to some certain condition, exercise rehabilitation to improve the physical endurance, and then coming to the pulmonary rehabilitation. Now, if they ask for what is the only thing that you would do, that would be smoking cessation. If they ask for in the CDM question, write 3 or more, then you are going to start with smoking cessation, vaccination, home therapy, and then SABA. And on the basis of if the person is having exacerbation, then you go for LABA. As this is here, guideline for the COPD. So early diagnosis, you are going to start with spirometry plus prevention. In the early diagnosis, you start with spirometry to confirm the diagnosis, then go with the prevention. Prevention is smoking cessation and vaccination, and along with that, whatever is needed. Then prevent, treat, and exacerbated or acute exacerbation of COPD. Assess for the features of asthma, if asthma is included in this one. Then coming to the end stage of life. So dyspnea, if it's in the very initial stage, you are going to start with early diagnosis and prevention. And along with the symptoms, if this is more than 10 symptoms present, as we already discussed the symptoms, so if there is more than 10 symptoms present, or if you can rate them more than 10, then you are going to start with the early diagnosis. And if this is up to 40, then end of this life care will be started. Like you are going to start discussing what you need to do at this point, maybe exercise or maybe all those physical activities which can lead toward the death can be prevented. Lung functional impairment, if it's mild, then do spirometry and prevention. If this is severe, then end of the life stage. So self-management and education, smoking cessation is one of the first line thing you are going to do. Exercise and active lifestyle, vaccination, short-acting bronchodilator. So in that scenario, if they ask, these are the things you are going to write down. Then if they ask, these things has been done, one is the next thing, inhale long-acting therapies, then next thing, pulmonary rehabilitation, then next thing, then oral therapies, then oxygen plus non-invasive ventilation, then lung transplantation. So usually we stopped at our level, which is basically oral therapies. Acute exacerbation. Now, this is a condition which prevents and presents in the emergency condition. So you are going to start with the definition, which is basically more than 48 hours has been passed with the worsening of dyspnea, cough, and sputum production, leading to an increased use of medication. So in addition, either prudent or not prudent, both can be present. So to predict the need for the antibiotic therapy. So viral upper respiratory tract infection, bacteria, air pollution, CHF can lead towards all of these conditions, can lead towards the COPD. Management, definitely it's an emergency condition. So you are going to start with airway, breathing, circulation, and then consider the non-invasive CPAP and BiPAP. If high carbon dioxide with a reduced pH, if as we already discussed, there could be high carbon dioxide trapped inside with the reduced pH. So O2 oxygen targeted 88 to 92%. So too much oxygen should not be given. Only 88 to 92% of saturation of oxygen can be given for the CO2 retainers. Then coming to the bronchodilators by the mid device inhaler with the spacer and nebulizer. So you are going to give that one. Then SABA plus anticholinergic via nebulizers, and 3 back to back every 15 minutes. So you have to give 3 times. So if they ask one time is given, what are they going to do next? Repeat. If they 2 times has been given, what are you going to do next? Then repeat again. So 3 times should be given. Then moving on to the next one. Systemic corticosteroids, oral prednisone. Since this is the emergency condition, you are going to do whatsoever. So you are going to start with oral or IV prednisolone. Then methylprednisolone. Antibiotics for the poolant, if there is poolant discharge coming out as in the cough, so you are going to start with the antibiotics. Patient with the no risk factors for the resistant antibiotics, so you are going to give with the doxycycline. Patients with the risk factors for the resistance, you are going to start with the amoxicillin. Post-exacerbation rehabilitation within 2 weeks if possible. So if they said if the exacerbation has been settled down and he is about to discharge, what is the one thing you are going to do? So you are going to do with the rehabilitation. So don't forget these small magic words. These can be used in the CDM question and can be asked in the MCQs. ICU admission for the life-threatening exacerbation, ventilatory support, non-invasive BiPAP, then conventional mechanical ventilation. Then prognosis, it's if this is not very exacerbated one and not very frequent conditions has been happening again and again, so it could be better. So what are those best scores? High probability the patient will die from COPD. 10-point index consisting of the 4 factors. What are those ones? Body mass index, BODE. B for body mass index, O for obstruction, D for dyspnea, and exercise. So based on these ones, you can see if there is a high probability of chances of dying or not. Okay, so if they give you a scenario where there is a body mass index of more than 21, obstruction is 50 to 64%. So with that, you can give the points and see if the probability of just give it a read. Okay, now coming to asthma. Yeah. So it's written in pediatrics and family medicine as well. And it's also written here. You can read it from there. You can read it from here. Here, everything is covered. That's why we are doing it from here. Otherwise, if you want to do it from family medicine, it's totally fine. There is a one nice table in family medicine that can cover the whole asthma and COPD as well. Now coming to the asthma. Asthma is okay. When is asthma diagnosed? After the age of 5, asthma is diagnosed. Before age of 5, you cannot diagnose asthma. Spirometry is used to diagnose asthma. Simple as that. Then airway obstruction, asthma, COPD, bronchiectasis, and cystic fibrosis. Red flags are severe tachypnea, tachycardia, muscle fatigue, diminished respiratory effort, cyanosis. Silent chest is one of the most danger sign in the asthma. Then decreased loss of consciousness. Then coming to central cyanosis is not detectable until saturation is less than 85%. And it is more easily detectable in the polycythemia, less readily detectable in the anemia. Then coming to the signs and symptoms, dyspnea, wheezing, chest tightness, cough, sputum. Symptoms usually occur or worsen at the night or early morning. Symptoms can be paroxysmal and persistent. When having an asthma attack, signs of the respiratory distress or pulsus paradoxus. Now, criteria for the determining if the asthma is well controlled. So, what are those ones? If the daytime symptoms is less than 2, nighttime symptoms is less than 1, physical activity is normal, and exacerbation is mild, it means it's well controlled. And there is no work-related activity. Beta agonist is not used less than 2 times. FEV1 is more than 90%. PEF, diurnal variation is less than 10%. So if you remember 2 times, one is night and 2 time in the daytime, if there is experiencing any of the condition, if the condition is exacerbated, definitely that you are going to use beta agonist. It can help you to find out if this is controlled or uncontrolled. So everything that's worsened or more than 2 times in the daytime or using beta agonist more than 2 times, so it is basically uncontrolled one. What are the irritants? All of those things that can cause asthma. Upper respiratory tract infection, emotion, cold air, exercise, GERD, cigarette smoking, and then strong scents, allergen, house dust, pet denders, mold, cockroaches. So these can be things. Along with the other ones is basically NSAID, NSAID sensitivity, beta blockers, and hormonal fluctuation. Just give it a read. Pulmonary function test for the diagnosis, as I already told you, it is only being diagnosed after the age of 5. It cannot be diagnosed before the age of 5. Why? Because spirometry needs to be done, and only if spirometry shows less than FEV1 divided by FVC decreased, only then you can label it as this is asthma. Before that, you cannot label it. More than FEV1, more than 12% after bronchodilators or the course of controller therapy is used, and if it's increased, then this is asthma. Alternative measurements is peak expiratory flow variations, and then positive challenge test, which is basically methacholine challenge test. Usually spirometer is preferred and only used to diagnose the asthma. Same goes for COPD. Spirometry is used to diagnose that COPD. Signs of the poor asthma control, same goes as we discussed. Daytime more than 2-3 times, activity is reduced. Nighttime more than 1 time, GP visits is more. ER visits or hospitalization is more. Rescue puffers used more than 3 times. Schools are the work absences there. Coming to treatment, you are going to start with the counseling. Treatment is basically identified. Patient education is very, very important. Telling them they have been suffering from which condition and telling them how to do the self-management and asthma action plan. Inhaler technique should be very important. If they ask in the asthma question, that a child or whatever person is coming to you and his asthma is not controlled. So first thing you are going to confirm is if they are using the inhaler properly or not. So inhaler technique is one of the most important thing before moving forward or doing anything else, because a lot of people has been using inhaler technique wrong. Pharmacological, then coming to the symptomatic relief in acute episode. So you are going to start with short-acting beta-2 agonist or combined long-acting beta agonist with the inhaled corticosteroid. So in these conditions, we use inhaled corticosteroid as a first line, but in COPD, we don't use inhaled corticosteroid as the first line. Long-acting maintenance can have any patients with the poor control or at risk of exacerbation should be on the inhaled corticosteroid containing regime. Risk of exacerbation defined as history of previous requiring of systemic steroids. So if the person has been already been admitted, so this person might need oral or IV steroids. Poorly controlled asthma, overuse of SABA, and more than 2 inhalers of SABA in 1 year, and current smoker. So this can help you to find out if there is a risk of exacerbation can be in the nearby future. So start with the daily inhaled corticosteroids. So this person need inhaled corticosteroids as needed in the patients more than 12 years, especially in the patient expected to have low endurance. Then coming to add long-acting beta-2 agonist to low-dose inhaled corticosteroids, escalate the inhaled corticosteroid dose, then long-term respiratory antagonist, and then long-acting anticholinergics, oral corticosteroids, anti-AG, and then interleukin-5 drugs can be used. So this can be prescribed after a long consideration. So we are just only going to stop until what we need to know. Asthma action plan is a written plan developed by the providers for the patients with the asthma, which includes the signs and symptoms for the patient to recognize acute loss of asthma control and personalized treatment reduction instructions for the each zone. Now coming to the emergency condition of asthma, you are going to start with the inhaled beta 2 agonist. First line, mid device inhaler, root, and then space device recommended. So that's why you need to know if the person is using it properly or not. Systemic steroids can be given if severe add anticholinergic therapy and magnesium sulfate to prevent further exacerbation. Then rapid sequence intubation is in the life-threatening condition. Subcutaneous or IV adrenaline can be used. If there is anaphylaxis, then inhaled corticosteroid maintenance therapy. How you are going to decide what you are going to do, if this is controlled or if this is uncontrolled. If this is controlled, then you can give SABA on demand. Along with that, environmental control, education, and written action plan and confirm diagnosis, and then discharge the patient. But if it's not, then you are going to move. If this is 6 to 11 year, then low dose, medium dose, and high dose, how much could be given. Then after more than 12 years, you are going to start with the SABA has been already used. So first line they have been using because he is a diagnosed case. Now you are going to, because he's coming to you, so SABA has been used and condition is not getting better. So you are going to add inhaled corticosteroid. That's why we are going to add inhaled corticosteroid at this condition. After 12 years, you can also add LABA, and if 6 to 11, then increased inhaled corticosteroids, right? They said they have been telling you if this has been done, what is the next thing you are going to do. So if the person has been already using SABA and inhaled corticosteroid and the age is 6 to 11, what are you going to do? Are you going to add LABA? No, we are going to increase the inhaled corticosteroid. And if this is more than 12 years, you can add LABA. Same goes if this is a 6 to 11 years inhaled dose of or increased inhaled corticosteroids has been done. What is the next thing you are going to? Then you are going to add LABA. And more than 12 years, you are going to do LTRA. And then in the end, you are going to do anti-IgE and then start the prednisolone, maybe orally or IV. So I hope this helps you, because in the 6 to 11, it's different. And after 12 years, it's different. So they ask these kind of questions in the exam, because what we do is we just remember the general one. We don't know in the certain type of age, what are we going to do. So in the 6 to 11, after inhaled corticosteroids, we have to increase the dose. And if still not being controlled, then moving on to LABA. So regular reassesses is basically if somebody is coming to you and his diagnosis is being confirmed as an asthma and his condition is not controlled or uncontrolled, both condition. So what are you going to do is you are going to check for the control, spirometry, inhale technique. Inhaler technique is very, very, very important because a lot of people miss this one. Adherence triggers comorbidities and sputum eosinophilias. Remember to step down therapy to lowest doses, which control the symptoms, signs of bronchoconstriction. So if the patient is controlled, move to the one step below. I hope this covers the asthma as well. So you can even do it from family medicine or from the pediatrics as well. So what is the next topic we are going to do? So the next topic is heart failure. So if you still have any question, please do x-rays of these ones. It's very important because on the basis of x-rays, they are going to ask you, or maybe they can ask you if you are able to see the diagnosis of on the basis of the x-ray. Just see the common ones like asthma, COPD, those ones are more important than anything else. So let's go with the so heart failure. Heart failure is congestive heart failure is one of the most common one. So low output and high output. You don't need to go into very of this pathology of it, just the basic thing. Left-sided heart failure, right-sided heart failure, and biventricular heart failure. So what happened in the left-sided, all of the fluid is accumulated in the lungs area. So elevated ventricular filling pressure, pulmonary vascular pressure, shortness of breath, fatigue, and weakness. So if you can remember, in the left side, all of the things which is included to the lungs will be filled with the air, with the fluid. In the right side, rest of the body would be filled. So increased ventricular filling pressure. So what happened is vascular congestion in the vena cava. So fluid accumulated in the lower extremities. So there is edema, ascites, all of these things would be present in the right-sided heart failure along with nausea. Biventricular will include both of them. Okay. So just little bit of ECG. If you could remember, the P wave will be inverted. Atrial fibrillation. So what happens is if the abnormal JVP function, if you can remember, it's good to go. If you cannot, just remember what are the differential diagnoses like atrial fibrillation, third degree heart block, tricuspid regurgitation, cardiac tamponade, and Kussmaul breathing or Kussmaul sign. Now coming to the sign and symptoms of left and right sided heart failure, low cardiac output, and then congestive venous congestion. So left sided will show all of those symptoms which will be included in the lung field. So that's why they are having those kind of things. So left sided will show syncope, systemic hypotension because all of the fluid is accumulating on this side. So along with peripheral cyanosis, pulses, alternate cough, and then crackles and dyspnea could be there, then leading to the right sided, there would be left failure, S3, and then edema is most commonly present in the right sided one. Hepatomegaly is there, ascites could be there, Kussmaul sign is there, then pulsative liver is there because all of the fluid is accumulated over there. Now, causes of the right failure, ischemia, non-ischemia is basically HT and diabetes mellitus, ethanol use, myocarditis, decongestive cardiomyopathy, then tachycardia induced. Heart failure with a mid-range ejection fraction output. Investigation. So most important things are investigation. What are you going to do and how are you going to identify? As I told you, you need to know the X-ray of cardiac heart failure as well. It's important. Then identify and assess the precipitating factor. What is the cause of it? Then treatable cause of congestive heart failure. Do that one first. Then go with the blood work, CBC, electrolytes, blood urea, one creatinine, both is important. Then fasting blood glucose, hemoglobin A1C, lipid profile, LFT, serum TSH level. TSH level is important. You cannot miss this one because it can lead toward the obesity and can be cause of it. Then ferritin, then BNP and uric acid. ECG, look for the chamber enlargement. If the T waves is enlarged, it can show that chamber enlargement, arrhythmias, and ischemia. Chest X-ray is one of the most important because the fluid is accumulated, so that's why it can help you to find out those ones. What happened is cardiomegaly is there, pleural effusion is there, redistribution. That's why I said chest X-ray is very important. Curly B signs and bronchial alveolar cuffing is there. Then echo, usually it's done by some cardiologist, but you can just write down in your investigations. If they ask in the CDM, you can write down echo. We are going to do the echo. Then radionuclide angiography, usually done by cardiologist. Then myocardial perfusion scintigraphy, also done by cardiologist. So we are going to start with the LMNOP. So treat acute exacerbating factors, starting with the position. As it's written as LMNOP, but still we start with the position, BiPAP, oxygen, nitroglycerin, morphine, and then Lasix. So because position is something we can do without needing anything else. So just doing the sit position, sit patient up with the leg hanging down unless the patient is hypotensive. Then BiPAP, decrease preload and need for the ventilation. So CPAP and BiPAP both can be used. Then oxygen in the hypoxemia patients, and then nitroglycerin. So you are going to give the IV, topical, or sublingual. Use with a caution in the preload dependent patients. And then morphine, decrease anxiety, and the preload Lasix can be used as an IV. In ICU setting or the failure of LMNOPP is done, then you're going to start with the nitroprusside, hydralazine, sympathomimetics by using dopamine, dobutamine, and then phosphodiesterase inhibitors. Usually that condition is being resolved with LMNOPP. What happened is if the patient is coming in an emergency condition and you are working as an emergency physician there, then you are going to start with LMNOPP. But if this is not controlled, then you are going to call for help and then start the nitroprusside for time being. If they ask in the MCQs, as in what they want to know your knowledge, then you need to know the nitroprusside and hydralazine. But in CDM question, you are going to think what you need to do as an emergency physician. Then dopamine, dobutamine, and then phosphodiesterase inhibitor. Consider the pulmonary artery catheter to monitor the PCWP. If patient unstable, obviously done by some cardiologist. Mechanical ventilation is needed, and then rarely used are these ones. So precipitants of heart failure are those ones, which is that hypertension. So Missing dose for hypertension is one of the most important cause of heart failure. Why? Because a lot of people think their hypertension is controlled and they stop using those medication, and later on presents with the shortness of breath and being diagnosed with heart failure. So missing dose is one of the thing in hypertension leads towards the heart failure. So endocarditis, maybe some infection could be caused. Anemia is one of the factor. Then rheumatoid heart disease. So rheumatic heart disease, thyrotoxicosis, failure to take medication is very, 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 very common. Then arrhythmias, infection, lung problems, endocrine, which is basically pheochromocytoma, and dietary indiscretion. So basically, people are eating whatever they want to eat. The most common cause of the right heart failure is the left heart failure. So if this is left heart failure is there, then right heart failure could be cause of it. Measuring BNP, if you can remember, then definitely go ahead. If you cannot, then it's fine. Long-term management, overwhelming majority of the evidence-based management applies to heart failure. Current no proven pharmacological therapy is used for the long term, but as you can start with the preventing fluid overload with the appropriate diuretic strategy. So you are going to start with the conservative management, symptomatic measures, starting with oxygen in hospital, bed rest, elevate the head. Then lifestyle modification is important. Then multidisciplinary approach for the patients. If the patient, because multidisciplinary approach is important because this person is facing shortness of breath. So they might have this anxiety and this is going on. So they need some motivational therapies as well along with these ones. And then some dietitian, some cardiologists. So that's why it's a multidisciplinary approach. Non-pharmacological management is basically cardiac rehabilitation. Coming to the pharmacological, this is they are talking about the long-term one. So you are going to start with the ACE inhibitors and then ARBs. ACE is preferred over the ARBs. So you are going to start with the ACE inhibitors and then angiotensin 2 receptor agonists. Then arrhythmia drug can be used, which is basically amiodarone or those conditions because it can be linked with the arrhythmias. And then coming to anticoagulants, if it's needed for the prevention of thromboembolic events, AFib, LV, thrombus, and these things, and ARNI, combination of the angiotensin receptor neprilysin inhibitors can be used as a first line or switching from ACE inhibitors. So if you are going to switch or the ACE inhibitors is contraindicated, then giving ARNI is preferred one because as I said, first line therapy or if switching from the ACE inhibitors can be used ARNI. Then coming to the beta blocker, because a lot of people start using after ACE inhibitors, they think beta blocker is the second line, but not. Beta blocker is not the second line. Then indication of the class 2 carvedilol improves the survival in the fourth class, and then caution should be used. Then diuretics, then digoxin and cardiac glycosides, hydralazine plus isosorbide dinitride, ivabradine. Then mineralocorticoid receptor antagonist, SGLT2 receptor based on if the patient is having a diabetic condition. So this thing here, chronic treatment of CHF. These are all the things that's written over there. What you need to remember is basically this chart or this table. Chronic treatment of CHF, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, diuretics, ARNI, inotrope, antiarrhythmias, and anticoagulants. So morbidity benefit, which gives the morbidity benefit is ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. So they can ask you for the mortality benefit drugs are ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. Rest of the things are they given, but they did not give the mortality benefit.